Thank you so much for being here today. Thank you for Headway for inviting me to talk about something that affects many people after brain injury, but isn't always entirely obvious. And we're going to be talking about cognitive communication disorders, or CCD. So hopefully, whether you're a family member, a caregiver, professional, or someone who's just simply interested in understanding brain injury better, welcome. So, as Colin said, my name is Anisha and I am a speech and language therapist who specialises in brain injury and neurorehabilitation. And I called the title Reconnecting After Brain Injury because that's what being able to communicate really enables us to do, enables us to make those connections between people. And as a speech and language therapist, that's what we do. We help them rebuild that ability to connect with family, friends, colleagues, and the world around them after their brain injury. And communication is vital to this. So I thought we'd start off by talking about and looking at what is communication. So often we tend to reduce communication down to the words that we say. But this is just our language system and only one aspect of our communication. So whilst we do have our conversations with people face to face, over a cuppa, over the phone, we also communicate via written and more often than not nowadays, emails. We may meet up as groups socially and over social media. So whether you're sending those DMs, posting a TikTok, they're all communications. But also the things that we don't also think sometimes so obviously about is being able to read our hospital letters, being able to make those appointments, being able to ask questions in the GP surgery. And like I said, everything is so digital now and online that, managing even our finances, being able to communicate through the apps that we're using. So ignore the labels here, but I just wanted to show a picture in terms of, or an image in terms of around where we kind of think around or typically used to think about communication and in the brain. These areas that are highlighted in different colours are in fact the areas that are involved in our language system. So that enable us to understand what people are saying, the words that they're using, and us to be able to move our lips and our tongue and our mouth to be able to say and find the words that we want to say. But as I've just said, that this is quite simplistic. This is only one aspect of communication. And if we look at it in more detail, actually, we can see that there's a whole host of other processes that are involved in communication, including our cognition, so thinking about what we want to say, how we inhibit what we want to say, how we don't inhibit what we want to say when we are really angry, how we reason through things, how we make those arguments to the gas guy who and the energy suppliers who are taking all our money, to how we are guided by our emotions as well, and they do affect our communication. So we know that when we're not feeling as great, we're feeling a bit blue, that we tend to not really be motivated to talk. We're not really forthcoming with talking. Whereas when we're anxious, we actually do speed up the rate of our conversations. So when we are in interviews, for example, when we're anxious about something, we might speak at a rate of knots. We become really hyper. And in terms of physiologically, fatigue, it's a huge impact after a brain injury, after most neurological conditions, and this can affect how we communicate as well. We tend to have more of that increased brain fog, finding the words. We might trip over our words, our speech production a lot more, the more tired we are. And that's all in addition to our communication. So when we're thinking about communication, so how we are listening and interpreting what people are saying, how we're processing that information, how we are explaining and using the words ourselves to explain what we're thinking and what we're meaning, and how we interact with people generally. And in terms of the non-verbals as well. So how we read people's cues, read people's body language, their facial expressions. And you can see by this image that essentially there's pretty much all the area of the brain that is involved in communication one way or another. But just to make it a bit more complicated, on top of this, we need to think about the individual. We're all different. And that's what makes brain injury really difficult sometimes. We're really individual people. So not only in terms of thinking about actually our age impacts the way we communicate. So obviously when we're younger, we might not have as much of the vocabulary. We might not always understand that actually in certain contexts or situations that we do change and adapt the words that we use, the language that we use. In terms of how we communicate as males is very different to how we communicate as females. In terms of how far or how much we have attended education, been able to, may affect our communication skills, as well as culture, our background, our linguistics, in terms of do we speak more than one language? Most people are, quite a majority of people do speak more than one language, not only bilingual, but multilingual. In terms of the communication style that we use. So are we a really chatty person, forthcoming? Are we really blunt when we talk naturally? Are we the person who sits back and listens to everyone? Or are we the really sarcastic joker in the group? And then in terms of the type of injury that we might have had, so the brain injury, in terms of the type of brain injury, the severity of it, and how far post the injury you are. These are all factors that can impact our communication. On top of that, just to make it even more complicated, is that actually the context that we're talking in. So who are we talking to? Are we talking to our family, our friends, people that we know, or are we talking to strangers, people that we don't know? And have a think yourselves, we do actually adapt and change the way we talk to people, depending on how familiar we are to them, and in terms of what context it is. So if they are professionals versus our friends. In terms of the environment that we might be talking within. So if it's at home, again, we're much more relaxed, much more familiar, versus if we're in the hospital or at a doctor's appointment or in the pub, or equally if you've got a court order appearance. And then the task at hand. So actually, what are we trying to do with our communication? Were we trying to retell a story? We're trying to retell something. We're trying to explain something. We're responding to a question. We're providing an answer. Are we asking a question? Also, are we asking for clarification? Are we giving an opinion on something? Are we trying to make an argument for something? All this really highlights the complexity of communication and the multiple processes that are occurring when we are communicating. And so after a brain injury, if we think back to the image that we had of the brain and those areas that are involved, it slightly makes sense that there is a high prevalence of communication disorders after brain injury. And if not more, the most often being a cognitive communication disorder. So any type of communication disorders can occur. So there may be language difficulties or aphasia. There may be speech difficulties in terms of slurred speech, so like dysarthria, voice disorders like dysphonia, or in terms of just communication, in terms of the CCD. What we know is that language, speech, and voice tends to only take up about a third of our communication disorders that we see. The overriding familiar one that occurs is a more highly frequent one that occurs is the cognitive communication disorders. And if we look back to that image of the brain and the overlaps, it may make sense and link to when we have, in terms of a traumatic brain injury, that diffuse axonal area that is impacted and injured. So what exactly is CCD, or cognitive communication disorders? So it can be defined as deficits in communication that ultimately arise from underlying cognitive impairments. So, for example, attention, memory, information processing, executive function, or social cognition. So this next slide is quite a crude aspect, a crude image. It's not linear. It's not one causes the other, but it's a helpful way to see, just to show and understand a little bit in terms of the complexity again. So in terms of those cognitive processes like attention, memory, information processing, awareness and insight, executive dysfunction and social cognition, difficulties or changes to attention might impact someone's communication. They may have difficulty following or changes in following changes in topics. So when we're talking and we suddenly change topic, they may have difficulty following that. They might get easily distracted by either internal thoughts or external. They might not be able to kind of siphon out and kind of reduce what the external other conversations might be happening around them. So noisy environments might be quite difficult for them. They might have difficulty multitasking. So for example, taking notes and listening to a webinar, for example. In terms of memory, so this might impact in someone's communication in terms of recalling kind of information from conversations. They may not remember the details of conversations. They may remember overall it happening. They may not remember that the conversation topics that have been had. And so they may repeat themselves quite a lot as a result, not recalling that actually we've had that conversation already. Equally, they may not find the right words or give enough details in what they say as well. In terms of information processing, they may have difficulty comprehending large amounts of information, either in written form or spoken. So they may be able to handle in terms of small amounts of information, but when it becomes a large amount, it may become overwhelming. It may become difficult to hold on to and process. It may take just a lot longer to process. They might misinterpret information or get the wrong end of the stick. So they may think or assume that they have processed and understood what is being asked, but as a result of maybe missing some of the details, they may have gotten that wrong end of the stick of what is being asked of them, for example. In terms of awareness and insight, we know that this can be impacted after a brain injury, and that reduced insight into their own communication changes can become difficulty. It can make it difficult for adapting and taking on and using strategies to support, and not just in terms of communication strategies, but it may well be kind of physio exercises or kind of OT adaptations, or kind of well-being strategies in general. They may have problems recognizing or repairing communication breakdowns. So, for example, if someone hasn't understood what they've said, they may just carry on repeating it in the exact same fashion, not understanding that they may need to rephrase or what they've said in order to help someone understand, or maybe they haven't said it in the most clearest way. And executive dysfunction. So they may have difficulty initiating conversations. So once you, they may always require that you need to start a conversation, but once they've started a conversation, they have no problem, but they will never start and initiate a conversation. And this can make it difficult in thinking about when you're talking to new people, when you are talking to unfamiliar people, when you're making new friends. It can be quite difficult if you're if both parties are never initiating. There might be difficulty ending conversations. So in terms of always maybe not just read the cues of the listener, of the other person trying to end, or they might not be able to realize that how to end a conversation. And we all do this, we think instinctively, but we do this, and we do it kind of consciously. Often there might be a lack of kind of structure or coherence in their discourse of what they're saying. So again, we all tend to talk and communicate with a start, middle, and end. When there is difficulty in terms of or lack of structure, they might start in the middle. They may have not kind of let you know what they're talking about. They may have just jumped straight in middle of their story. And that makes you as the listener quite lost in what they're trying to say. They may be verbose, so they might talk for a lot longer than is needed. They may go on and on. They might say something that maybe only needed a sentence, but they talk at length about it. They may be tangential, so they might go off topics when talking. So you may ask them how they were, and they're talking about what they're going to eat for Christmas. They may also make quite often literal interpretations. So particularly in English and our language, we have a lot of idioms, metaphors, similes, words that are not taken literally. But some people may have difficulty with this after brain injury. They may not get that you're making a joke, or that you are not really meaning that when pigs fly, or that you're trying to actually split hairs. And then in terms of social cognition, so in terms of, as I've slightly mentioned already, reading people's emotions, thinking about things from their point of view. So actually noticing that someone's looking upset, and so maybe what you're talking about is upsetting them. We would normally do that and then stop talking or move on. They may just carry on, and they may well have recognized it, but they may have difficulty due to executive dysfunction around doing something about that. They may appear or have reduced empathy, and so they themselves may not give a lot of information non-verbally to you. They may have difficulty, as I said, perceiving humour or sarcasm. So in terms of sarcasm is often quite a big one. So they will understand what you're saying, but the tone that makes it that sarcastic tone, so that you know that actually that was a joke, or they're trying to humour you, may go completely over their head. Or they may become egocentric. So in terms of they are only able to think from their perspective. And so conversations need to be around what they want to talk about, for example. So just to kind of really bring it home, what CCD kind of looks like is if someone is struggling to stay on topic, if someone is forgetting conversations that they've had, they might tend to be repeating themselves, might be misinterpreting tones of people's tone, their jokes or their sarcasm. They might dominate conversations or speak impulsively. They might struggle to tell stories in order in a coherent order, or they may miss out details in that story that they're saying, so it doesn't make sense. They find it hard to read the room. Their skills may commonly fluctuate dependent on the environment that they're in, the fatigue impacting them at any particular time of the day, and the stress that they might feel within the environment that they're in. And that they might not always be aware of these communication changes. But it is worth noting that every person with CCD is different. And so they may not, it's unlikely they will have all of these symptoms, but they may have any number of these. Yeah. And the impact that this has on a person and subsequently to their injury is that it has a real impact. So their relationships. So it has difficulty in terms of maintaining those relationships, in terms of starting new friendships. We know that evidence shows that, research shows that we tend to lose our social networks, so they become reduced after a brain injury. And so there is often a bigger need to make new friendships. But like I say, if you're not initiating, if you're coming across blunt or rude, or you're not kind of really hearing what the other person is saying in that pragmatic sense, that can be really difficult, particularly if the other person doesn't understand the changes that you've had and the difficulties that you're having. There's research showed that in terms of participating in leisure activities really reduces. So it becomes really difficult to participate in activities that might have given them pleasure. It may be difficult, again, thinking about the social aspects of, so you may be able to go play paddle, but there's often a whole social aspect to it as well. And if you've got difficulties with those social interactions, that can become quite difficult, even though kind of physiologically you can play paddle. In terms of academic attainment, so in terms of getting an education, so remember, brain injury can happen at any age. And particularly if you're a child or a young person with a brain injury, it can change the trajectory of your development, and it can make it difficult to access education. It can also impact in terms of employment, so returning to work. So in terms of maintaining work as well, the biggest, so I think CCD and communication disorders is normally the biggest reason that people don't maintain their jobs, because again, those social interactions, those appropriate professional interactions can be quite hard for people. And if you're not always aware of your communication changes, this can make it difficult and impact on your autonomy and independence, as well as your identity. So how we speak, what, like I was saying, in terms of our communication style, of if we were the joker, if we were the kind of strong, the really good listener that people went to, and now you're completely the verbose one or the really blunt one, that can really change who the kind of identity that you had, and kind of your self-identity and how you're identifying yourself. And a result of all of those, it can really impact on someone's mental health and well-being. So if you're not really being able to access your education, if you're not being able to hold down a job, if you're not able to participate in things that you enjoy so much, that's really going to have an impact on your well-being. And it's important to realise that it's not only an impact on the person with a brain injury, but communication is a two-way process, and it takes two to tango. So it does have an impact on the other person as well, particularly kind of close family members, caregivers. So there's an increased family and caregiver burden. It can be quite distressing if it's quite severe impacts. There's a might be shifts in roles. So if that person used to be the breadwinner, for example, and they're no longer able to go to that employment level that they were at before, and so they may well still be in employment but in a different one or a lower kind of pay scale, that might have a financial implication. They might have been the caregiver themselves and they're no longer able to do that, and maybe their partner is now having to be the caregiver for someone else that they were giving the care to. So what some families have said, because it is subtle, so he sounds fine, but something's different. She keeps asking the same question. He never used to say inappropriate things. Conversations are exhausting now. And so there's real subtle changes where there's not something specific that people might not be noticing, but there's something different. There's something that's changed in that person. And then it's worth highlighting that there are even longer term consequences if we aren't able to intervene at an appropriate time with people with cognitive communication disorders. As I said, it may affect that person's childhood development if they have that injury quite as a young person. There's an increased risk of criminal behaviour, which also, once they are in the criminal system, leads to poorer legal outcomes as well. So again, if you're thinking about them understanding what's occurring, what's happening, actually in terms of what all that legal jargon is, they're put at a major disadvantage. So often CCDs are overlooked. And why are they overlooked? Why are we not picking them up as much as we know that they have such huge impacts on? It's because they often talk better than they communicate. So in, for example, aphasia, which is the language disorder, we can, again, it's more visible. We see someone not being able to find their words and therefore thinking they're not able to talk. But actually people with aphasia can communicate really well, because it's just one part of their communication that's affected, their words. And so they're able to often problem solve and learn new ways to adapt. So using kind of a total communication approach, thinking about, can they write it down? Can they mime it? Can they gesture it? People with CCD, as they, like I said, what they say makes complete grammatical sense. But actually, when you look at the content of it, there's not much there. And so it gives the impression that they are able, there's no difficulty there. And just to say, in terms of, there are a few papers, so if you are professionals out there listening today, that have come out. So there is the INCOG guidelines that have, the second reiteration has come out recently in 2023. That identifies what we as speech and language therapists should do, and how we should support someone with a cognitive communication disorder. And in the newly updated NICE guidance for the rehabilitation for chronic neurological disorders, including brain injury, it highlights that we need an early SLT referral, but we are part of the MDT. The MDT should be doing early screenings of all communication changes, referring on to us to screen as well. And that we should be working as part of MDT in an interdisciplinary way and providing that cognitive communication rehabilitation to individuals. And as part of RCSLT, so the Royal College of Speech and Language Therapists, there will be new guidance coming out on not only acquired brain injury, but also the around CCDs early 2026. So how do we, as speech and language therapists, support someone with cognitive communication disorders? So I'm not going to go through this, but you can see there's a whole host of things that we do, and it's not just in an inverted commas therapy. In first place, we need to identify it. We need to assess. We need to see how they are communicating, and importantly, how this has changed from how they would normally communicate before their brain injury. What has the change been? And how are they communicating in different environments? So often in hospital, it's quite short interactions. They're quite visual kind of aids of what to expect. And so people with cognitive communication disorders may not get picked up so easily because it's not so challenging in terms of complexity for communication. And so it may not be so visible. Once we have assessed and identified, a lot around it is around education of how that communication has been affected after brain injury and how it's affected them, and tailoring intervention for that individual. So that cognitive communication rehabilitation involving being very communication specific, context dependent, very and meaningful to that person. So it needs to be in that environment that they're having difficulty in, with the communication partners that they might be having difficulty in. So if they are having particular difficulties in the workplace, it would be working with the workplace and the employers. And there's a whole host of things that we might also do alongside that education and that as part of that cognitive communication rehabilitation is think about using assistive technology, or kind of our everyday, and by assistive technology I mean in terms of our everyday technology that we kind of use. So, you know, using our smartphones, using our electronic calendars to help us remind us of things, of have those strategies written down. Work collaboratively with families, friends, caregivers, the MDT, work with third sector organisations that provide often and now more than ever so much input. So I think people like Headway. We may work on raising someone's insight and awareness into their communication difficulties. Working in groups and not just one-on-one, as kind of that is a whole added complexity for someone in terms of our communication. When we're on one-on-one, we can focus on one thing, we're focusing on one person and what they're saying. In a group, we're having to look at lots of different people, lots of different things that are going on at that time. In terms of how to refer to SLT, so anyone can refer. You can make that referral via your health professionals, and it can be made at any point after the injury. If there are new circumstances, new contexts, increased problems that you might notice further down the line, then you can go back to your GP and make a referral and request for that. So thinking about kind of just tips for, like I said, everyone with CCD will present very differently to each other, but some general tips. So if you are the person with CCD, thinking about preparing and planning for conversations. So, for example, if you've got a hospital appointment, doctor's appointment, thinking about if there are particular questions you want to be able to ask, having that written down, taking notes during, or if the multitasking is difficult, you know, using a recorder, using someone with you to take those notes. So you are able to ask those questions. You remember to ask those questions, and you're able to say what you want to say as well, and you're not put on the spot. To keep speaking clearly and concisely, to think about, are you going off topic? Oh, am I talking for too long? What tips, what hints are giving me that? In terms of, as I said, record information, use your phone, use your, take a picture, take visuals, aids for that, and check that you have been understood by people, or check you have understood them. So reiterate back to them so you can check that you haven't misinterpreted something. And then just some general tips for if you are working or living with someone who has a brain injury and CCD. So follow any strategies that may have already been provided by speech and language therapists. Ask the person themselves what helps. But in general, reducing noise, reducing that, making that environment calm, not stressful, not noisy, reducing distractions can always help. Allow time to respond. I think we're all really bad at wanting to fill in that silence the minute that there's a silence, but actually if you can count to 10 and give that silence, give that time for someone to process and respond is really helpful. Break information into short chunks. Don't give huge amounts of notes and visuals to help cement that understanding. Highlight to them if you feel able to, in a gentle way, that they've gone off topic, that they are speaking for too long. Use clear, concrete, everyday language yourself. Don't use like loads of convoluted if you don't need to be using that. Provide visual formats, and it may be helpful to revisit conversations as well. And it's worth just saying that it is often a tightrope that you have to walk between being really supportive and not being overly supportive, and allowing them to also work on it. So they may well be working on it as part of their rehab as well. Some additional tips for specific context that you might be working in. So in education, you might be wanting to think about that teaching classroom environment, where that person is sitting, using visual aids to help organise and learn information. In terms of the workplace, so if it has lasted or is likely to last more than 12 months, the ABI counts as a disability under the Equality Act, and so does CCD. So if communication is impacting, so you may want to think about it likely needing a longer phased return to work, having information pre-written, people not putting you on the spot so you're getting overwhelmed, employers fostering a culture of compassion and patience and tolerance. And then in terms of in terms of health and social care professionals, ensuring that you are providing accessible information, assessment and treatment materials, supporting information in terms of decision making about health, finance, housing, the really complex topics that we need, and use a lot of complex words as well. How can we break that down? Do we need to be using that jargon, particularly within the criminal justice system? So avoid using that complicated legal language. Support them to complete documents. In the criminal justice system, you can use an intermediary service, which is often made up of speech language therapists, but not always. So where they will support and ensure that these adjustments are put in place and supported if needed. And just some further resources. So in terms of for professionals, there is a cognitive communication checklist for acquired brain injury called the HABI, and this gives 45 reasons to refer to a speech and language therapist. So it's free if you Google it, and you can download it. It's a really easy tick box, and if you tick any of those areas, then it suggests that there's a requirement to refer to SLT. There is an open access CCD article about CCD by Dr. Susan Howell on our role as SLTs. So that's a really nice, easy read as well. Like I said, in terms of guidance on CCD for the speech and language therapist, it will be coming out early next year. So watch this space. Okay, I'm just wary of the time, so I'm going to skip over that. But just to really highlight that communication really is more than words. It's how we connect and belong and make sense of the world. And when that changes, it really does affect every part of our life. And we're not picking it up as much as we should. And that's because it is very invisible. It's part of that hidden disability, and they will appear often better than they are. But it does affect in terms, particularly around their social interactions, and simple strategies like taking notes, preparing ahead of time for things can just make to do that, and identification to help with that. So by understanding CCD, I hope we can build a better support system, strengthen those relationships and reconnect in more meaningful ways. Thank you.